All right, well, thank you for the invitation to speak. So I'm Josh Peterson. I'm an internist, and I'm a clinical informaticist, so I think I'm a zebra of a different stripe in this room. I have a lot of association with some of the NIH-funded consortia that are working on translating genetics to clinical practice, so the eMERGE network and the Ignite network. And we have an institutional program that I help run called PREDICT. So I'm going to spend today talking about pharmacogenomics, but I wanted to motivate the discussion a little bit by going back to a paper I had the opportunity to work on in 2003, which was essentially a New England Journal paper to catalog the number and type of adverse drug events that occur in ambulatory care patients. And the bottom line is if you give 1,000 patients a prescription, of course it's a broad range of prescription, and you look at what happens to them in the next 3 months, you'll find that there's a lot of adverse drug events. Most of them are what we call significant, so perhaps sort of an annoyance to patients, but a few of them are serious. And the other lesson from this study, it focused on the preventable adverse drug events, but the large majority of these events were considered non-preventable. My job was to, as a fellow, was to basically look at every single one of these and write a little vignette. And so I remember them well, and in fact, the non-preventable ones were things like serious cutaneous adverse reactions, side effects from SSRIs, NSAID-related GI events, and beta blocker-related bradycardia, where, particularly at that time, you'd shrug your shoulders and say, well, there wasn't much we could do about that at that time. And I think what's exciting about pharmacogenomics is that for some of these, there are emerging pharmacogenetic stories. I think the stories are, in some cases, early, and we don't yet have sort of the implementation plan for every single one. But there is one, that top one, where there's been some great success stories. And I hate to do this after lunch, but I just wanted to remind everyone that there are some very serious drug reactions that are rare. This is Stevens-Johnson syndrome. And probably one of the greatest sort of pharmacogenomic success stories is actually not in the US, but in Asian countries that have required genetic testing before giving drugs like carbamazepine and identifying patients who have this HLA variant and thereby preventing the onset of not only this disease, but an even worse disease called toxic epidermal necrolysis. So the flip side of the coin, which I think we've touched on many times this morning already, is that there is a frustrating lack of drug efficacy for many of the common drugs we use in primary care, and this leads to sort of a cycle. Well, let's try this drug. Well, how about this one? And that tends to not only erode the confidence of our patients in the therapies that we prescribe, but also to expose them to a greater number of potentially adverse event-causing agents. So I like to put, originally I came from the drug safety realm, and now I do a lot with pharmacogenomics, but my original research was how to implement age-related prescribing concerns and renal clearance prescribing concerns in a clinical practice. And sort of my soapbox now in pharmacogenomics is that it shouldn't be thought about in isolation. And so a lot of the work that was talked about this morning I think is really applicable to the area of predicting and optimizing drug response. That said, most of the data that we have to work with in pharmacogenomics is one variable at a time analyses, and we'll look at some of that. So if we look at sort of the end goal, it's to take these variables, among others, and be able to integrate them into a prescribing decision aid that is really able to help clinicians and other prescribers sort of integrate this into a single decision. So in pharmacogenomics, this again has been touched on. There's a spectrum of evidence. I think the left-hand side, one of the nice things about genetics is you have a lot of confidence in the fact that you have close to 100% reproducibility if you find a variant, and you'll find that same variant usually with a couple trouble spots on multiple platforms. So the left-hand side is sort of taken care of, and then you have a huge body of evidence that is sort of labeled by the NIH as clinical validity type evidence, where the top two GWAS and PWAS are fairly exploratory, and then the bottom two types where you correlate with phenotype testing or you do cohort studies or genetic sub-studies to look at candidate genes. And this is honestly what we mostly have to work with when we're thinking about implementation. We would like to have more clinical utility, which will include randomized trials and comparative effectiveness, but we have to sort of make decisions about what we're going to do now today with the evidence that's in front of us, and most of that's in that middle category. So I did want to go through some examples of that type of evidence. We've got, this is sort of a paper that launched a cottage industry in genetics, which is to look at the clopidogrel-CYP2C19 relationship. And on the left-hand side, you have pre-clopidogrel exposure. On the right-hand side, you have clopidogrel exposure in the absence or presence of a variant of CYP2C19. And it just shows that there are essentially different platelet aggregation responses when you look at the different genetic substudies. So this sort of led to some reanalyses that were well known of RCTs. And again, it's one variable at a time. This is the one that shows the clearest signal by Jessica Mega, showing that carriers of CYP2C19 have a higher event rate primarily in patients who are undergoing PCI. And then you have a weaker signal in a paper that was published very close in time. But again, it still shows that the top curve, which is the CYP2C19 variant patients who have had acute coronary syndrome, and they're also treated with clopidogrel, they tend to do worse. So there's been a little bit of confusion of exactly how big a signal that is. But I did want to say that we have completed a comparative effectiveness study, so including patients that wouldn't be included in those two RCTs, and finding that patients treated with clopidogrel who have a loss of function do comparatively worse. And again, this is a cumulative incidence curve showing that they have more cardiovascular events over time compared to patients who are treated with an alternative. So we would like to have more of these comparative effectiveness studies and RCTs, but what you run into, and I think this really is applicable to implementation, trying to figure out how to apply the evidence to clinical practice. This is an example of a genotype-guided azathioprine care. Azathioprine is a common immunosuppressant used in inflammatory bowel disease and other autoimmune diseases. And what I'm showing you here is actually the enzymatic activity graph from the paper, because the paper is a negative paper from respect to outcomes. But here's the enzymatic activity, where patients without a variant have a nice bell curve of enzymatic activity at the top. And in the middle, they have a heterozygous for the variant, and they have, it's sort of skewed to the left. And at the bottom, they're homozygous for the variant, and they have no enzymatic activity. So that is exactly what is predicted by the basic science, and it shows up quite beautifully in this study. And in fact, that one patient who was homozygous for the variant was the only patient in the entire trial that had a severe neutropenia from azathioprine and survived, but had to be hospitalized. And so the challenge is, what do you do with a paper like this? It's ostensibly negative. Perhaps it wouldn't pass muster among payers. But it has a clear validation of what you would expect from the pharmacogenomic effect. So I'm going to switch gears just a little bit and talk about what we have done in the pharmacogenomic realm in terms of implementation. This is just an overall graph of what is called our PREDICT model, which is essentially our way of getting people tested multiple different ways. On the right-hand side, we get them tested, for example, in the cath lab. If the physician would like to know their CYP2C19 status, that's an option for them. And then we also have a group that is essentially institutionally funded to get tested before they need any of the therapies. So the idea is to get the information into the record before it's useful, because otherwise there's a lag that becomes a great implementation barrier. You get genetic test a week after your prescription, and you've already incurred a week of risk related to that prescription. So we have 15,000 patients in this program, and this is sort of a partial list at the bottom of the drugs that are targeted. And the whole concept is that most of this happens in a semi-automated fashion, so that even if you got tested several years ago, you still get some information pushed to you at the right time. And so I'll show you a little bit what that looks like. First of all, I wanted to mention that it used to be that we would do our own systematic reviews, and try and make sense of the literature. And at this point, we really don't have the bandwidth for that. I think that would probably be true for just about any health system you would approach. And so we make heavy use of the CPIC guidelines, which are essentially run by folks interested in genetics, and they don't always agree with the specialty guidelines, but at the same time, it's what we have, it's the best we have. And we engage our clinical experts, and we get institutional approval. So this is sort of our evidence approach to making decisions about what genes we test for and what drugs get implemented. Behind the scenes, we sort of automated the result to interpretation pipeline to make it as quick as possible. And so, as soon as the lab sort of signs off on the result, within just a couple minutes, you get an interpretation that shows up in the patient record in a couple different places so that people can sort of find these results easily. And then if they do try and prescribe a drug that has a variant that potentially affects that prescription, you probably can't read all the words, but the whole idea here is that in some cases we're offering them alternatives. This is a patient who's being prescribed clopidogrel and has a variant, and the alternatives for the post-stent patients are prasugrel and ticagrelor. Now, again, you probably can't read all this, but this is actually something that's quite popular, and I think it's a good example of how all of the data can come together. Of course, warfarin has 3 to 4 decades of pharmacokinetic and pharmacodynamic studies behind it, and there's been a number of risk models around trying to reduce both the bleeding risk and the clotting risk. And so we have implemented this using a model that was derived from our own patients, which we demonstrated worked better in terms of the amount of predicted dosing error compared to the published models. And one point I wanted to make is that this actually is a pretty popular type of clinical decision support in our institution, meaning that we get an 80 and 90% acceptance rate of the offered dose. So sort of the bottom line is we think this is how much warfarin you should get as a starting dose, and we get a lot of uptake on that. Whereas if we ask people to change drugs, that's sort of cognitively a bigger deal for them, and they end up sort of accepting that advice depending on the scenario 30 to 60% of the time. We also, I just want to make a last point, which is that we do try and get these results to patients. This is through our patient portal. And so I don't know if this is completely adequate in terms of educating them about their pharmacogenomic results, but is a very scalable way for patients to get access to results so that if they go outside of our institution, they still have a way to sort of refer back to kinds of genetic variants that we found. I want to acknowledge a large group of faculty and program and technical staff. Thank you.